All right, it's awesome to see such a full crowd. Thank you all for coming down to San Diego. Now, regardless of where you are in your DPC journey, I promise you this discussion is going to be an enlightening one. So whether you're contemplating work with employers or you're already deeply serving your local community, we have some interesting data to show you all. So this is how we're going to spend our next 35 minutes. We'll do some quick introductions, and many of you are already really familiar with our esteemed panelists. We'll really dive deep into the data, but ultimately, we're eager to hear from all of you. So we've set aside 10 minutes towards the end for audience Q&A. All right? So without further ado, I'll introduce Dr. Ben Aiken, family physician, founder and president of Lantern Health, a thriving DPC practice nestled in Asheville, North Carolina. And Dr. Aiken's dedication extends beyond his practice. He's also an advisor and was the VP of Health for Decent Health, an organization trailblazing and striving to make sure affordable health insurance is accessible to all. There's Nick right there. Woo! All right, next we have David Contorno, renowned benefits leader. David is the president and CEO of ePowered Benefits. His mission is to make sure employers have access to understandable, navigable, and affordable health plans. He's actually been recognized by Forbes as one of America's most innovative benefits leader for his stance on transparency and his stance against oppressive tactics of VUCA. Fun fact, I know you didn't include this in your bio, you host a podcast with your wife, Emma Fox, called The Healthcare Hangover. I tuned into quite a few episodes on my flight over from Boston, so check it out. All right? And my name is Xiao. I am the Senior Network Development Manager at Hint. My role is to work with all of you DPC clinicians to build and grow our curated network, Hint Connect. Prior to joining Hint, I spent more than a decade in quality program management at various institutions from Tufts Health Plan to Athena Health and Boston Children's Hospital. And needless to say, DPC communities really holds the key to transformative changes in primary care, so I'm really glad to be here. Before we dive into the specific data, I want to provide an overview of our data source. So a huge shout out to our data and analytics team, especially Emily Murray, for working tirelessly and putting together meticulously our data set from our proprietary database. So included in this data sample, we have more than 3,500 DPC clinicians serving more than 1.1 million members by collaborating with more than 6,000 employer sponsors. So let that sink in. This is a huge data set. So if you haven't already, go ahead and scan the QR code on the screen. Fresh off the press, download the full report. Within its pages, you'll find a wealth of insights that go beyond what we'll include in our panel today. All right? Don't miss out on this resource. With that, shall we dive in? Let's do it. So the first thing we wanted to take a look at is really how did employer sponsor grow over the last 5 years? And I think the numbers speak for themselves. There has been more than 800% change from 2017 to 2022. To put that number into perspective, in 2017, we had less than 700 employer sponsors, and now we've soared to over 6,000. So I'll start with you, David, from your vantage point of ePowered Benefits. Does this align with your observations and expectations?
Absolutely. We are doing DPC in 100% of our plans, both new clients and renewals. And while there's a hesitancy, because of the way we build our plans, for them to choose the DPC, because they have to change primary care doctors, every single person is rating a 90-plus NPS score for the DPC plan. They appreciate the relationship they have with the doctor. Their specialist visits go down, their specialty medications go down, their outpatient visits go down, and it is returning care to what it was supposed to be, both for the doctor and for the patient.
That's awesome to hear. What about you, Ben? What do you think?
Yeah, I think my sense is that this absolutely is happening. Prices continue to go up with the typical VUCA plans, double-digit percentage increases, and businesses for several years have been fed up, and they're increasingly fed up. So more and more businesses are just facing this financial burden of saying, gosh, I just can't do the status quo plans anymore, and they're looking for alternatives. And the word is spreading. So, like when we opened 5 years ago and we had an initial employer, like I would never meet an employer that's ever heard of this. And now some of them have, more and more seem to. And quite a few are actually seeking it out from us. So it does seem that there is awareness around what DPC is.
Absolutely. And do you all think that this rate of growth is going to be sustainable over the next 5, 10, 15 years?
I think there's going to be a supply side issue. In other words, there's not enough doctors coming into primary care if DPC really took off. But if we build up the demand, the supply will come. And I think more people, more students will go into primary care. And maybe even we could get the US government to make it easier for doctors from overseas to practice in the US. But we spend less on primary care as a percentage of healthcare than almost any other nation, even though we're spending more on healthcare than any other nation. And so we need to bolster primary care, and that is what this conference is about.
I love it. What do you think, Ben?
Yeah, I think the supply question is something that I think about a lot, and for all of us that are DPC docs in this room, like I think we're up to the task. We've had some challenges, I think, in terms of meeting supply with a big enough geographic footprint. But if the demand is there, then that eases that transition for generally very risk-averse doctors in terms of coming in. So I think that that's, if we get the commitments from the employers and that space continues to take off, I think it will enable the growth and a faster rate of growth for the DPC.
Absolutely. And to do a quick plug for Hint Health, in addition to our technology, we also have our accelerator program, our Hint Connect DPC network. We're doing a lot behind the scenes to also help clinicians, residents that are curious about the DPC landscape to get you all off to a successful start. So with that, let's take a look at the percentage of DPC clinicians working with an employer directly, right? So interestingly enough, we actually are seeing this rate holding steady for the last 2 years. So between 45 to 50% of DPCs have worked with at least one employer sponsor, but that suggests about half of them are not. So Ben, why do you think that is?
Yeah, I'm actually, as a public health geek, I'm looking forward to digging into this data to try to understand it, because it frankly caught me as a bit surprising to see that we actually haven't seen the percentage of DPCs working with employers increase. It's really just stayed stable for 2 years. I think where I'm mainly focused is that we are seeing more employee lives, and so it seems that practices that are used to working with employers are increasing that volume, and so they're meeting, again, the supply issue is really where I want to be focused as a DPC doc and growing the movement. I do think, we'll speak to it some, there are some barriers to getting DPCs, to work with employers, but I'm mostly interested, I'm not as worried about that staying stagnant as long as the overall volume is increasing.
I'll come back to that point, but David, I know you've worked with hundreds of DPCs through your self-funded health plan. Have you ever had to convince a DPC practice to work with employers?
So oftentimes when I call a DPC and say, hey, I have a client who's in your geographic area and I would like you to be the primary care doctor, if I get their voicemail, I feel the need to leave this protracted voicemail saying, hey, we're not going to put pre-cert, prior auth, step therapy on you. We're going to honor everything. We're going to pay your monthly fee. And there's this hesitancy to work with employer plans because they're used to working with Blue Cross, United, Cigna, Aetna. And what I want the doctors in this room to know is that there is an alternative model, a model that honors the patient and doctor relationship. One that says, hey, doc, you've gone to school, you've done your residency, you earned the right to treat this patient. And we need to get back to that. Employers need to understand that when you put Blue Cross or United or Cigna in the middle, you're not just putting one layer in the middle, you're putting 3, 4, 5, 6 layers in the middle. And you are not only taking away from the outcomes of that patient, but you're adding to cost. And so I honor all the doctors in this room who say, I want to give care to this patient directly. I want to not be encumbered by hospital administrators or insurance carriers telling me how to treat my patient. That's what I went to school for. And when you bring that back to the care model, the quality of life goes up so substantially, and the cost of caring for that patient goes down. We know that 82% of patients in our model of direct primary care never has a specialist visit at all. And we're talking about the most comorbid, diabetic, COPD patients that you can think of. But when you have a family medicine doctor who is trained to treat patients and has the time to treat them, that is what primary care is all about. It's called primary care because it's where you're supposed to go primarily.
I feel the passion from your response. Now, Ben, to circle back to your earlier point, certainly there are barriers, perhaps concerns, right, amongst DPC clinicians that are curious about working with employers. Now, how did you overcome some of that during the early years of Lantern Health when you were exploring working with employers?
Yeah, I think, for us, recognizing that 50% of the payers in this country are employers, it just felt almost like an obligation to try to engage with that population. So it was kind of just, we're going to do this and we're going to figure out how to do it. So in terms of, it was more the overcoming the barrier, figuring out how to sell, get people to commit, and then, commit, basically give them what we say we're going to give them. It's more work.
Yeah.
Being really frank, like we work harder for our employee patients than we do for our retail patients. Getting them engaged can be harder versus, if somebody calls you on the phone and says, hey, I'm going to pay you this per month, like they're going to come in pretty quickly, whereas if somebody else is paying it on their behalf, they may not. So getting them engaged, and that's what they're paying us for. Like they want, employers want, it's a failure for us if people are basically being paid for and they're not coming in. That's not what we're out to do. So that's one. The turnover is higher, certainly in today's market, and a lot of people are changing jobs, and it's pretty dynamic, and we try to give them a path to stay on with us, but a lot of people lean on that employer payment and don't stay with us. And then there's some, expectation about reporting. I think it's a mix. We're very intentional to make sure that the reporting that we are focused on is actually meaningful and not burdensome. And there's tech tools that are here and in this hall that are really working hard to help us do that. And I think we need to convey them that value, but it's more work. My retail clients aren't saying, hey, can you give me a quarterly report on how you're doing on my care? It just doesn't happen. So I think for us, it feels like worthwhile work. Like our growth, about 55% of our patients come from businesses. And a testament to that growth, I've done zero marketing for the last 24 months to employers. And we've had to turn off employers for a couple months earlier this year because it's just word of mouth that continues to grow. And I think that's a testament to it being a really great area for DPCs around the country to continue to focus on.
Thank you for that. And you mentioned attrition rate, so that actually is a great segue to our next set of data. What we wanted to do is really show and explore what does it look like when employers implement a DPC benefit, right? A lot of clinicians ask me, hey, I'm concerned about working with employers if a majority of my panel is from one source. If I lose that contract and I've staffed up in order to serve those members, what happens the following year? So to orient folks to the graph on our screen here, we looked at retention rates for more than 12 months, which is just year 2 implementation renewal in the indigo colors, and then we've looked at retention rates for more than 24 months, which suggests year 3 renewal in the maroon columns. And we actually separated out employer sponsors based on the size of enrolled members. And as you can see, especially for employers that have more than 6 enrolled members, right, DPC is a very sticky benefit. The renewal rates are really, really high. But interestingly enough, for the smaller companies that have 5 or fewer enrolled members, they do have higher churn rates. So I'll start with you, David. Does this align with your experience at ePowered? I know you work with self-funded, so maybe they're not this small, but what do you think about that?
The way that we do our plans is that we offer employees a choice. One plan will allow them to see any doctor they want. And then one plan will embed a direct primary care provider in which they have to see that DPC, who we often bring to the open enrollment meetings. And so there's a big change for these people. They have to change their primary care doctor, their pediatrician, their OBGYN over to the DPC. And so there's a hesitancy for them to move over. However, once they do, and in our plans, we get 50 to 70% of employees to pick the direct primary care centric plan at open enrollment the first year, they love it. I mean, there's when you build plans outside of Blue Cross and United and Cigna and Aetna, there's a lot of friction. There's a lot of change. There's a lot of different pain points than they're used to. However, when you put in direct primary care and when you make that direct primary care provider the center of care within the benefit plan, as they should be, the result from the patient is off the charts better. It is, they appreciate they don't have to pay a copay. You know, I was in a client meeting where we were rolling out DPC, and I said, they were very blue collar, and I said, how many of you in this room have been to your primary care doctor for your once a year annual physical that took you 3 or 4 weeks to even make the appointment? And then when you get there, you get your 7 minutes with your doctor, an hour and a half past your appointment time. How many of you have said, when the doctor says, is there anything else I can help you with? And you think, you know, I've had this ear infection or this rash or this headache or this sinus infection. How many of you have said, I don't even want to bring that up because all of a sudden, I'm going to go from zero out of pocket to something out of pocket? And half the room raised their hand. And so, to me, that said, when you get your 7 or 11 minutes with your primary care doctor once a year, you're too afraid to say what is bothering you. How is that a healthcare system? And so in DPC, you can say whatever you want, and you can spend as much time as you want, and you're not going to pay anything out of your pocket. That is the miracle of what primary care should be, what it was 40 years ago before I was born. That is what we need to return it to. And for the doctors in this room who have already flipped over to a membership model or who is considering it, I applaud you because you are fixing American healthcare. You are making people healthier, and I am grateful for you.
And it sounds like education and awareness of direct primary care really is key to this. Now, Ben, I know at Lantern you've worked with employers spanning all of these sizes. Does this resonate with your experience?
Yeah, I mean, if we're focusing in on the small, I think, okay, well, hey, the 1 to 5 is the highest turnover, lowest retention. Our experience at Lantern has been mixed.
Yeah.
You know, we have some businesses, our smallest business, I think, has 3 employees, and they've been with us for 5 years, and we've had small businesses that have signed up and go under 3 months later and leave. So I think that I almost think of kind of, let's say, independent contractors or individuals who are out there trying to navigate exchanges and kind of find something for themselves or at an extreme disadvantage. I think small businesses are in the same disadvantage. The price point to get in on traditional plans is exceedingly high. You can't spread the risk at all. And then generally they're not actually required to provide coverage, and so there is almost this expectation in that segment of not providing it. But small business owners care deeply about their team, and it's so intimate and small. It's like a family, and so they want to do right by their employees, and so they are looking for options that are out there. We have most in this space just provide us. It's suboptimal. If something happens that requires a hospitalization or somebody gets a diagnosis of cancer, they're bankrupt within 48 hours, and that's a reality that a lot of Americans face every day. So we really try to push folks in that space to have more comprehensive plan, but it's really hard. The most common thing we see now is medical cost-sharing plans, and we're continuing to tell Nick and the Decent team to come to North Carolina because there are folks that are looking at that population and trying to serve it better at a price point that's affordable. So it's been a mixed experience, but because it's that kind of, I think we've heard a couple times today, this like, there's this underlying kind of social justice thread that a lot of DPC docs have in terms of serving people that otherwise aren't getting the care that they need. And I feel that small business community is in that underserved bucket.
Yeah, I'm sure
that really
many
needs a better option.
Yeah.
So it's mixed, maybe higher turnover, but worth it.
Thank you for that perspective. Now, we've warmed up, so I'm going to put you in the hot seat, David. What do you think employers look for during renewal season?
What I think they look for and what I think they should look for are two different things. For those of you that don't know who I am, I was a traditional health insurance broker for 18 years until I said, I can't bring bad news to my clients every year, year after year after year. I'm going to change something. I'm going to do something different. And today we build plans that are totally different, and they save 50, 60, 70%. They honor the doctor-patient relationship. And so the answer to that question is it depends. If an employer is looking to add on DPC to their Blue Cross and Blue Shield plan, I actually think that hurts the movement, because if you just pay $50, $75 a month per employee to have this direct primary care relationship, but yet you can still go to your spine doctor without a referral, without going to your DPC, you've just added cost to the plan. And so if you build a plan in a way that and I see Dr. Jeffrey Davis, Brandon Alleman, where we say, this is your primary doctor. This is who you go to for everything. The need for the specialist goes down substantially. And when you do it in that manner, when you encourage the relationship between the patient and the DPC doctor, and when they develop a relationship between the patient and the DPC doctor, you will not break that. You will have such retention among employers because their employees will be saying, holy mackerel, you gave me a plan where I actually know my doctor, and more importantly, my doctor knows me. There's no replacing that. And I will tell you guys that the path I've chosen to build plans outside of Blue Cross and United and State of Atlanta is difficult. It is really difficult. But with the help of the direct primary care doctors in here, many of whom we work with in our plans, it eliminates all that. It restores care to what it should be, which really is patient-centric. At the end of the day, the problem with our healthcare system is that it benefits people who are not the patient. And when we look to build a plan that says, hey, when the patient wins, we win, that's all you need to do. Like, literally, that is all you need to do. And it changes everything. And so I know that some of you know that we build direct primary care into every single plan that we build for every single employer. We are building direct primary care. So for those of you that I haven't worked with yet, I'm coming. When I find a client in the area that has employees of you, I will call you. But I want to say one other thing. Our best referrals over the last couple of years have come from doctors, like many of you, who has a patient who owns a company and says, wow, your care is so great. How do I bring this to my employees? And so I want to encourage the primary care doctors in here to become quasi-health insurance advisors who connects them with the right people. And I'm not the only one. There's others out there. But connect you and your client with the people who will build a plan that restores primary care to what it is supposed to be. That is what I'm looking to do.
Thank you. And I have been following your work at ePowered for some time. I know on your website you've shared through your performance plan, on average during year one, there is 29% cost reduction already observed by the employers. I think that'll go a long way to renewal conversations at the end of the year, for sure. Now, in the interest of time, we're going to take a look at our last set of data. And the reason we explored this is because I get questions a lot from clinicians such as yourselves, what type of employers actually implement direct primary care, right? And what we've done here is we actually took a look at our 6,000 plus employer sponsors, separated them out by industry types, and there were more than 40. And then we grouped them into 4 major cohorts. We have the light pink columns leading the industrial goods and services. We have the hot pink with consumer goods and services, followed by public goods and services and professional goods and services. For the sake of this particular graph, we've only included the top 4 most prevalent industry types in each one of the 4 cohorts. If you want the details, feel free to reference our full report for all of the other types. Now, this tells me, right, there is no specific niche for direct primary care implementation. It works well, and it works great across a wide spectrum of labor and industry types, potentially with employees of all ages with diverse healthcare needs. So, Ben, I'll start with you on this one. Now, as you can see, we have construction, food services, healthcare taking the lead when it comes to becoming early adopters of primary care. Do you see that at Lantern, or why do you think maybe they're a little bit different than the rest of the industry types?
Yeah, it's a good question. Our experience at Lantern has been very consistent with that. Asheville, where I live and practice, is a service town. It's a tourist town, and we have a lot of restaurant workers, hotel workers, and so the food service space is certainly probably our highest level. On the construction manufacturing side, we have some in that sector as well. And then on the healthcare side, I think, just speaking to that, I think it seems a little odd sometimes. You think of like, well, none of our clients are kind of a big integrated health system. But what we do have, and what you still see, I think, in communities all across the country, are small, independent health care providers, whether it's a dental practice, a physical therapy practice, local pharmacies. We have all of those that see the benefit. They want to have really strong teams. They understand the healthcare system a little bit more than a typical employer would, and they are seeking it out. So that does resonate, and I'm glad to see that seems to be happening in other places as well.
Great. And for David, what's the ideal client profile at ePowered, and does this resonate for you?
I'm not sure that the industry is what's important. What I think is important is an employer who actually knows and cares about their employees. And when they think about their lowest paid employee who's on their health insurance plan, who has a $5,000 out of pocket. And I want you guys to understand that for a lot of people in this country, a $5,000 out of pocket is $5 million or $50 million to many of us. Like, it is beyond understandable. And so it's not so much the industry, it is the employer who really understands and cares about their employees and is willing to put a stake in the ground and say, I'm done. I'm not going to do this anymore. And it tends to be more blue and gray collar, family-owned businesses, but it doesn't have to. This will work in private equity. This will work at Google. This would work at literally every employer-employee relationship in the country. But there are certainly different segments that embrace it quicker. And this is happening. And I want you guys in this room to know that when I started in insurance when I was 17 years old, 30 years ago, I never envisioned making doctors' lives better. That was not part of my career path. Like, I was selling insurance. How do I affect doctors? But as I transitioned into this model, and I realized that not only can I make direct primary care doctors profitable and able to survive, but I can actually help doctors flip from the hell that is fee-for-service over to DPC. That, up to this point, is the crowning jewel of my career. And hopefully it progresses to where I make healthcare better for patients. Like, that's like across the country, that's where I'm going. But right now, the fact that I can make doctors' lives better is a huge honor to me. And I thank you, all of you, for being willing to move into this model.
Thank you for that. And now I'd like to turn our attention to the audience. If you have a question, just raise your hand and we'll make sure we get a mic over to you. Quick note, David does have a flight to catch after, so if you have any questions, this is the time to ask. Otherwise, you're going to have to find him on LinkedIn. Do we have a question back there? Oh, right here? Go ahead.
So this question's for David. David, I know working with employers is one of the big things we want to do in DPC, and a lot of us out here work with employers, and a lot of us have probably run into brokers that are mal-incentivized, and it's hard to work with those people. I know our big thing is getting relationships with those business owners, but do you have any tips for us to work with businesses or their brokers?
First of all, so a lot of people call our healthcare system broken. I don't think it's broken. It's working exactly as it was designed to work. It just wasn't designed by doctors, patients, or employers. So it's not working well for those three entities. And so to answer your question, you have to get in with the employer directly. You have to say, thank you, broker, for making the introduction, and I will honor that, but I want a direct relationship with the employer as well. And when you get that message into the employer and you help them understand that just like most of healthcare, brokers make more money as costs go up and you make more money as costs go down, that is the fundamental difference. That is what employers need to understand. They think that United makes more money as costs go down. They think if they reduce reimbursement rates, if they deny claims, that they make more profit. And because of the medical loss ratio provision, that is not true. And so when you get them to understand that you are literally bringing benefit to their employee, both financially and clinically, you have to get that to them directly. Because when I was a traditional broker and I was paid commission, if you actually saved money and lowered claims, I made less money. Why would I want you to be in there? And so you have to turn that dynamic around, or at least make the employer aware that that occurs. And then the next step, and maybe the more aggressive step, is to find the very few, there are some, it's not just me, but there are some consultants and advisors out there who don't get paid more as costs go up, and bring them into the mix. I will tell you guys that our greatest referral source over the last 2 years has been direct primary care doctors. And when I say to an employer, while Dr. Jeffrey Davis is on the call with me because he introduced me to an employer, when I say, and I remind them that doctors hate health insurance, they hate it. So for them to refer a health insurance guy into the mix, there has to be something different here. That's when things start to change. And so your biggest obstacle is getting employers to understand how healthcare and health insurance actually works, which you guys came to understand by flipping over to DPC. But that's the hard part. It's psychology. It's really very difficult psychology. And I feel myself like I'm a therapist more so than I am an insurance salesman most days.
Oh, there's a question.
I just had a
go ahead.
question about specialty care. So if you do have to do a referral to a specialist, how does that work? I mean, are these employers, do they just have PPO plans they're offering for the employees? Or if they have an HMO, typically you have to do a referral for that. So how's that working, I guess?
Again, I'm going to imagine that the way we build plans is pretty different than most, but we do not utilize a PPO network. And so our quote network is any provider out there. However, every single one of our plans says to the members of the plan, if you allow us to direct you to where there's high quality care and upfront affordable pricing, the member pays no out of pocket. And so what we've developed is a DPC handbook that helps the direct primary care doctors understand how to quickly, easily, again, not asking for permission, just directing, how to direct them to a specialist that will accept the plan and is high quality enough, has the best outcomes enough to allow for zero out of pocket. And that's been a challenge for us over the last couple of years. We've had to literally say, hey, doctors, let me show you how to do this. But because they have a cash pay network, some of them, or just people in the community. But when you actually look at outcomes and costs, you'll find that higher outcomes result in lower costs. And so when we can arm the DPCs to say, hey, you actually need an orthopod, I'm going to refer you to one, but this is one that doesn't do surgery when it's not absolutely the right thing to do, or has the best outcomes, has the lowest infection rates and readmission rates, the member gets no out of pocket. The employer who's funding this pays less because that care costs less. And so that's what we arm to do, is to show these DPC doctors how to refer to care that is high quality and reasonably priced.
Ben, what's been your experience?
Yeah, I mean, on the DPC side, I think our experience has been mixed. It really is dependent on the employer. So it's very much when we're having conversations with employers about the plan, we have this conversation of, hey, here's what we bring to the table, but can you talk a little bit about how you build your network or lack of network or RBP or whatever approach you're taking, so that we are armed and ready to be able to take advantage of that, utilize that on behalf of the member. And when plans that are to the level that David is describing are there, like, it actually enables us to actually create a better experience and send folks to the right place. And I would say in general, there is some type of a care navigation team member coming from David's side that helps facilitate that when it's warranted. And then on the other end, we have, I think, employers that really have no clue and may actually have a pretty traditional network, and we just feel a responsibility, just like we do to any of our members, that if we send them somewhere that costs a whole lot and turns out is poor quality, like, that's a bad reflection on us. So we work hard to leverage our own cash pay networks, or who we know is good from X, Y, or Z reason. Or I've actually leveraged employer data from somebody who's given me quality data on providers to send folks that are not part of that employer group to that same provider, because I know that their quality is really high and their cost is really fair. So it's a mix, but it definitely is. When we started, it was never part of that initial conversation, but there are things that happen outside of our walls, and if there are things that are out there, like knowing how we can team up to do that better is really important.
All right. I know there are more questions. I'm so sorry we have to end here so David can catch his flight. Thank you for our panelists today. And make sure you download our report.